Well, Jim Lindsay is my name. ACC Family is the company. We're been in serving the DC area for 31 years. Going to be 32 years in a week and a half. So we're coming up on our 32nd anniversary. We're family owned and operated, and I was the first and only employee when we came on. So now we have about 150 employees, and we have 8 offices in 3 states. So we are love doing what we're doing and get to serve folks and having a blast. So that's who I am and where I fit. And I'll go ahead and share my screen if that works. Okay. Make sure everybody can see it. So this is our opening slide because sometimes this woman looks like sometimes we feel it's like, oh my goodness. And so I want to go through just basically the costs of care. I am not an expert on Medicaid, Medicare parts A, B, C, and D. So when we get down to there, you may know more than I do. But I'll go over just kind of what's happening in the world and then how much does it cost to age in place. So let's see here, get my next slide. Um, I always put this in here. Why am I doing this? Because we love certainly Arlington Neighborhood Village, and the Arlington Neighborhood Village cares about people. And I just got to tell you, I think I told Gary earlier and Liz earlier that I'm sort of a walking commercial for the villages and Arlington Neighborhood Village in particular, because I think that's how we're going to survive this aging process that we're going in. So one of the things I always do is I say bluff, bottom line up front. I've got lots of information, and we're going to skip over some slides because there's just too much to put in the time that we have. But I want to start just by saying we think in terms of layers. There's no one solution that works permanently when we're in the aging process. And I literally think it takes a village. You know, Hillary Clinton wrote that book years ago, It Takes a Village to Raise a Child. And I think it takes a village for us to live into our aging years. And so it does take a village, and I think the village movement is how we're going to survive the aging side of the world. Professional help is very available, but we always say only get professional help when you need it, because aging is a long process and it's challenging to burn up some of your resources before you need them, and then you end up running out of them. And so we say only apply professional help when you need it. And then it's no secret, harder days are ahead. So we say save your resources if you can. And this generation that we're talking to now is already accustomed to saving. And so we're in a good place. Someday we'll have Gen Zs headed into aging, and they're not accustomed to saving. So we might have some interesting challenges. Not us, our children and grandchildren, but it is important because it is more challenging days are coming ahead. And so then the one thing I always say is, and this I agree with the Alzheimer's Association and home care as a whole, is we always say protect the primary caregiver. And so if you're alone, your primary caregiver may be a daughter, a son, a relative, a neighbor. If you're married, often there's one spouse that has a greater health than the other. And we always say, whoever is the primary caregiver, protect that person best you can. Because if what normally happens is a spouse will care for their less healthy spouse until their health breaks, and then you've got two broken people in the room, and that's when things get even more complex. So these are the overall points that I'm going to start with, and then we'll get into the data. So again, you can throw me a question anytime you want to, and I want to see, make sure I got the chat up so I can see it as well. Um, okay. Uh, this is really funny. Good news is that we're living longer, healthier, and wealthier. The bad news is that we're living longer, healthier, and and wealthier than ever before. So the updated stats on our life expectancy for now, 78 for all of us lumped together, 75 for males, 81 for females. Ironically, Japan and Monaco are outliving us, and there's lots of discussion of why that is. But for the most part, we are living longer. And I said at the outset, my father-in-law, who is the chairman of the board emeritus of our company, is 94. My mother-in-law is 92. And still living at home, still doing great. So all of us are living longer, and we're tending to outlive our savings. And that's where the challenge comes, is how do you pay for care, and how do you navigate this care environment that we have in the United States in general, and in the Washington, D.C. area in particular. So now I put this rather complicated chart because I'll refer to it more than once. But this is a client path or a life cycle path for most people. So if you start up here in the very far left-hand corner, you have an independent senior who is living in their own home and they're day-to-day doing well. And then there is just to the right of it, there may be a low-income independent senior, but for the most part, then you hit that square, the red square, you have a triggering event, whether you fall down on the ice, almost burn down the stove, or you fall down trying to do the laundry, or something happens and you end up in the hospital. So if you follow my chart, you go to the far right, the hospital, and the hospital serves you. And then after the hospital gets done helping you get patched up, they send you to a rehab center. And the rehab center helps you get a little more patched up. And then they send you home with skilled home care. And the skilled home care helps you get, hopefully, better. And then you can maybe follow up with, down here at the bottom, non-skilled home care if you need that. And then you have family that works with you and you're back at home. But then you have another triggering event, and you can see on the outside circle, you go round and round on this circle with triggering events. You fall down, whatever, and then you go to the hospital, rehab, skilled care, maybe non-skilled home care, then your family helps you, and then you have another triggering event. And so this is a cycle or a circle that occurs in most lives of Americans. And you can see down there at the bottom, 82% of all Medicare expenses happen in the last 2 years of life. And it's because what happens is you have a triggering event, you go to the hospital and you go through the circle, but you're not better. You're technically better, but you're not feeling great. And then you fall down again and you start around this path. Now I have the center circle, which is hospice. At some point you say, I don't have any ability to go any further. And then you have hospice. And then down at the bottom, you have a municipal care, which means that you're low income and you're being cared for by a city or some other contract. But the reason I put this up here is that this system is running out of money. That's the challenge. And because we're running out of money, the tendency is to go around this circle faster and faster. And so the whole point of my talk today is, how much does all this cost? And then how do you stay out of that circle? Okay, so who covers the costs? And the thing about the unfortunate nature of it is this system, I'm going to go backwards, this system is episodic. That's the word in healthcare. That means you go from episode to episode. And because you're going from one episode to the other, the first episode you come out of the hospital and they patch you up, but it's not chronic. It's not a chronic condition. It's only episodic. So that means that you get fixed up for something that happens, and then something else happens and they fix that up, and then something else happens. And the more you go around that circle, the less healthy you are. And so the mission is, let's stay out of that circle if we can. Okay, so now globally, healthcare is episodic. It's not chronic. There's only a few places that cover chronic healthcare. And with that, that's where most of the cost is in the chronic side of the world. So Um, who's going to pay for us? Let's look at Social Security, Medicare, and Medicaid. So Social Security, ironically, most of us have it. Otto Bismarck came up with this idea in 1889. He was the first one that put in some version of Social Security in Germany. They they came up with a age of 65, and they said when you turn 65, you'll start getting paid by the government. The only problem is that the average age expectancy in 1889 was 43. That meant that you were dead 27 years before you got care for the government. And ironically, they've never changed that number of 65. It started in 1889 and it's still holding. Now it's in the US, it's moving towards 70. You can still get something at 62, and then you're getting more at 65, and the government is trying to help you to stay working till you're 67, and you get full benefits in the United States at 70. So you can see they're moving the retirement age up because now the system is running out of money, and you would need ideally to work a little bit longer. The German retirement age just moved up to 75. So you can see that's globally, governments are running out of money to pay for all this. And so therefore, they want us to live longer and keep being a person that doesn't drag down the system or doesn't become a beneficiary of the system. Ironically, if you use the same formula today that Bismarck came up with in 1889, you would start getting Social Security at 109. So that's a little bit of the way that it's working. So, little background on Social Security. I'm not going to read all this because you can read it, and I can certainly make these slides available if you're interested. But it started out small, and it was in 1937. It was just sort of a backdrop to the assumption is that people would care for themselves, and their families would care for them, and so they just had a little 1% payroll taxes, $3,000 cap, annual revenue, and then it was just sort of a backdrop. Now it is mainly for a lot of people what they're depending on to live on. So in 1951, there were 16 workers for every beneficiary, and in 2020, it was down to 3 workers for every beneficiary. Shortly, there will be 1 worker for every beneficiary. So the Social Security system is quickly running out of cash to work with. Now, I need to say, Social Security is not going bankrupt. If you see that, that's just fear mongering. That is not true. It won't go bankrupt. But what it will do is as the money that comes in matches and then exceeds the money going out, the benefits that you will get from Social Security, Medicaid, and Medicare will start to decrease. And we'll talk about that in a moment. So, oops, wrong way, sorry. So this is a smart asset suggestion. I put this in here just so you have what some people are thinking of. There is these strategies, you can say, this particular thing said if you're going to plan around Social Security, you should put more of your retirement funds in high-risk portfolios, focus on tax alpha, how much are you paying for your taxes, cut spending, and work longer. So you can see everybody that's in, well, not everybody, but many people that are in the finance realm are starting to think of how are we going to pay for our life as we get older. So,
Jim, can you explain what that phrase tax alpha means?
yeah, thank you. The tax alpha means what is, and that's a finance phrase that is used. It is just what is the most efficient use of your revenue versus taxes. So you minimize your taxable income. That's a phrase that Smart Asset uses. I think it's kind of a inside phrase, but it just basically means how can you maximize your revenue that you save and minimize your tax burden. Thank you for that, Gary.
Hmm.
Um, so Medicare, 4 parts to it: hospitalization, doctor, Medicare Advantage, and prescription drug. And again, I'm not an expert on all these different things, and thankfully so. but I want to give you just sort of the feel of what is coming for Medicare. The fund right now is set to deplete in 2033. That means the money that comes in will go immediately out the door. So in 2033, the incoming revenue will begin after 2033 will only cover 89% of the costs that they're currently covering. So whatever you're tapping on Medicare right now, you're getting 100% of what they can give you. And what is that, 7 years from now, um, you'll only get 89% of it because the fund is depleted. Now, this number moves around a lot. In 1982, I've got a slide on this in a little bit, but in 1982, actually this went down to zero, and they had Congress jumped in and made a law in 1982. So last year, this was set for 20. They said it would deplete in 2036. 2 years ago, it was 2050. And this year, it's 2033. So that number is really squirrely. But the bottom line is it's coming down to where Medicare, the hospital insurance fund, is going to go to break even, and then our benefits are going to start declining. So those of us that are not yet in the Medicare system, that's the future. Now, there's lots of different solutions, legislative mostly, but I'll just continue to give what is the current situation. The problem is that we have a whole bunch of unfunded obligations, and this is benefits that the government has promised but does not have a direct funding mechanism to pay for. So you can see that the Medicare is 52.8 trillion unfunded. That means that's all of us are expecting to get a certain number of benefits to the tune of, at the moment, 52.8 trillion, but there's no direct funding mechanism to pay for that. So technically, we're supposed to get it, but we may not. And so you can see that Social Security is underfunded. Federal Employees and Veterans Administration is unfunded. There's a lot that's out in the world right now that is showing fiscal volatility, to say the least. So if you drove, this is just so you know, if you broke it out, this is how much it costs right now, the unfunded liabilities, cost per citizen, for all of the, if you lumped all that together and then made every citizen in the United States pay for these unfunded obligations, it'd be $277,000 a person. So that's how far behind we are in terms of paying for everything. It's pretty grim. Now, Medicare Part A, it was estimated that it would run dry in 2024, but then that's changed, so the numbers are moving around. Now it's 2033. It's going to go to 91% of benefits after 2033 at the moment. They just changed the inpatient hospital deductible to 1766, and so that if you're right now using Medicare Part A, they just increased the inpatient deductible. That means you have to pay 1736 out of your own pocket when you enter the hospital, and it's currently brings in about 89 cents for every dollar of expenditure for Medicare Part A. And there's some, with the backdrop of Medicare, Medicaid, Social Security running out of money, there's all sorts of things now that the rules are changing and you have to be aware of. So there's a lot here, and I will just mention these things. A big problem is that you can go to the hospital and they put you in as under observation, and they don't admit you, they just observe you. And what that means is because you're not admitted, you're paying for that hospital stay per day. And so you have to make sure that you say, hey, if I'm going to go in the hospital, admit me. Don't just put me in for observation. I want to be admitted. The DC stands for Discharge to a Certified Medicare Rehab. They are, when they're trying to get you out of the hospital sooner. And so they're sending you to a Medicare rehab facility. The first 20 days are covered. The 21 through 100 days, if you're in rehab, you and I have to start paying $194.50 a day. And then 101 days or more, you pay 100%. So this is Medicare Part A. It used to be that it was just covered. And everybody thought, well, I'm going to go in the hospital, Medicare will pay for it. Not so much anymore. So these are updated to um, the real-time numbers in 2026, best we could find. Now, there was a question in the chat. Um, it's what happens if a person is admitted and moved to hospice? Hospice is 100% covered, but you have to, hospice, I'm not going to assume anybody knows all this stuff. Hospice is where you forego reparative or restorative treatment and you just are in pain management. And so hospice is right now, my data shows 100% covered. So if you're in the hospital, you'll pay whatever version of how many days you've been there. And then if you go to hospice, then hospice switches over and hospice picks up the tab. Hospice is a great thing. I'll talk about that in a moment. So Medicare Part B, it's funded by payroll taxes. They're starting to limit the ability of people to get paid, providers to get paid. So PT is physical therapy. It used to be 95% range of motion, for instance, was what was covered, and now they're dropping it down to like 75% range of motion is what you can charge Medicare for, and then you have to discharge them. So they're starting to limit the amount that you can use Medicare Part B. So the premium deductible this year is up to $202.90, and the annual deductible is at $1,736. So the question in the chat is, what about Medicare supplement policies? I'll get to that actually next. And then, yes, I can give the slides to everyone so that you have this. Here's Medicare supplement, Medicare Advantage. Here's this is way too much for me to talk through and for you to read now. So that's why I want to give you these slides. But Medicare Advantage was the attempt to say, let's privatize parts of Medicare and see if it can work. And so this is just a description of Medicare Advantage, and the current system in the marketplace is that the Medicare Advantage plans, which again sort of privatized some of Medicare, a lot of them are not being able to make it profitable, like United Healthcare and Cigna and some others that have Medicare Advantage plans. And so a couple of those plans, a couple of those insurance companies have dropped out, and they're no longer offering Medicare Advantage plans because it's really challenging to be profitable. So those are things that you would need to be aware of, and we're just finished open season. So if you're interested in getting more and more data on Medicare Advantage, I can maybe direct you to some folks that know more than I do. Medicare Part D is the prescription drug part, and these are just general slides about Medicare Part D. But the one thing is that that they're wanting to cap some of the most expensive drugs, and so right now they're dropping some drugs off Medicare Part D, meaning you have to pay for them yourself, but they're adding some others and they're putting caps on them so that people like doing insulin, for instance, will have less expensive insulin, and they're capping the costs on some of the drugs in Medicare Part D. I obviously do not have a list in front of us right now. And one of the questions is Ozempic or other weight loss drugs going to be a part of Medicare Part D? And that's open question right now. A lot of people don't know. So that's just a brief overview, but you can see that little green line is where there is dedicated funding for all the costs, Part A, B, and C, and D, and we're falling behind on a dedicated funding source. And that's not news to anyone, especially now that we're this far into this presentation. But the easiest way to say it is that if you're depending on Medicare, Social Security, there's a lot of volatility on those programs, and probably in 7 years or less, your benefits are going to begin to drop. And so now is the time to begin to plan. So Um, I just said this. No one knows what to expect. Again, the end date of the Medicare Social Security Hospital Insurance Fund is moves around on a yearly basis. But these are all just different things that can begin to cut in order to keep the program funding. So and yeah, I see in the chat, Medicare supplement plan is not the same as Part C Advantage. So, um, and also in the chat, do we know of any Medicare Advantage providers that are nonprofit versus profit? And I do not know if any of the Medicare Advantage insurance companies are nonprofit. I'm aware of Catholic Charities has a real large presence in the Midwest, Colorado, Utah, California, Oregon, Washington, and I assume that they are doing Medicare Advantage and that they're nonprofit, but I don't know for certain. That's an excellent question. And most Medicare Advantage companies are starting to deny claims, which is super frustrating to everybody. So the the system is very volatile, and so um, now's the time to start looking at other options. Okay, I will cover Medicaid briefly. It's low income seniors and
Well,
disabled
Jim,
folks.
before you do, can you talk about Medicare supplement plans and what those are?
I would be remiss if I talked about those supplement plans because the complexity is something that I'm not in a position to give great details on. It's just that the overview is that insurance companies have said, we will take you on and we will cover certain parts instead of Medicaid. And then I'm sorry, Medicare. And then the insurance companies get a bulk one-time payment from Medicare to cover the people that are in those Medicare Advantage plans. And in essence, Medicare is taking the care of Americans and outsourcing it to an independent insurance company for a for a per person price. And those companies then are managing your care. And uh, and some of those plans, the plans are moving all over the place because they're trying to cover certain things and not cover other things and deny claims. And it's it's pretty messy at the moment. Um, and you in the chat, Linda said supplements are commercial policies that will cover some of your Medicare deductibles and non-covered expenses. So there's a lot of complexity, and I would be a very poor um, person. I am not totally informed on all those yet. So thank you, Gary. Sorry, I wish I could be. Um, Medicaid, I'll just talk about this briefly. Medicaid is for low income seniors, and it's folks that are, it's a federal grant that is given to the states, and the states manage it. So Medicaid um, is also running short, and I think it is looking at 2034 runs out of act. I mean, it hits break even and starts running, dropping into or dropping the amount of coverages that it will offer. One of the things that Medicaid did, and Virginia was a part of this, is that it expanded coverage under the Biden administration, and the it added a bunch of people to the Medicaid rolls, and it on paper there was a plan that said it should have worked, but it is questionable whether it's working or not. And Virginia, which I'm not an expert on the legislation, but Virginia said we will take on a bunch of Medicaid folks with a grant from the federal government, but if it gets to a certain point, then we will no longer pay for those things. And it may be getting close to that. I'm not as familiar with the legislative side of the world yet. I don't think anybody is. But Medicaid, like Medicare, Social Security, is beginning to run out of funds. So folks that have Medicaid are like Social Security and Medicare are headed for some challenging. Now Medicaid covers about 95 million people. It's huge. Um, Here's some just updates on the Medicaid, what they're looking at in 2026. Some of the things stopped, which you already knew. Some of the Obamacare stuff stopped at the first of the year, and or will stop at the end of this month. And so there's lots of funding cuts that are coming inside Medicaid. And again, the um, it may not hit those of us who are on this call, but it will start causing people to lose coverage. Uh, this is just a chart on Medicaid growth and where it's coming from. I'm a commissioner on the City of Alexandria Commission on Aging, and we're very interested in this because we are looking at low income folks in the City of Alexandria that we're serving. So we're watching the Medicaid growth and funding as it impacts people that are low income. Okay, more bad news, but national debt is growing. And what we're doing now is a challenge to all these programs because the national debt factors into whether or not we can pay for the benefits that we've promised. So right now it's at 38 trillion, um, and this is as of last night, and it is growing by about $1 trillion every 100 days. That's our national debt. That's un, that's almost unfathomable. And so we are way above our GDP as far as national debt goes. And the Congress is having real challenges on trying to get the debt under control. And so those of us who live in the DC area are experiencing the DOGE cuts and the elimination of a bunch of federal jobs and cutting contracts and USAID and all sorts of attempts. Whether we agree with those cuts or not, those are attempts to try to cut down the expenditures because we're really headed strongly into a challenging situation with the national debt. Now, we're not alone in this. Most countries across the globe are hitting the same issue. So we're not alone in this, but you can see that the national debt is becoming quite a challenge, and it will impact those of us that are on Social Security, Medicaid, and Medicare. So a couple just different slides on it. Um, I thought this was interesting. I was listening to CNN News, and a House member said that China is waiting for us to implode on this national debt thing so they can take over. And you go, oh my gosh. Um, there is just a ton of chatter if you're in those echo chambers about the national debt. So I'm going to skip over some of this stuff because I want to get to good news. But here's just how the federal government spends its money, where does it allocate it, and then let's look at options. The first thing that here is just a list. We have a hospital rehab going from the top down, skilled nursing, PACE, which I haven't talked about yet, but we'll talk about in a moment, then home care and hospice, and then independent living facilities, continuing care retirement communities. Those are shortened to CCRCs. We have assisted living, then you have home care, adult daycare, villages, and I put in there in parentheses NORC. That stands for Naturally Occurring Retirement Community. Then we have granny pads or pods and intergenerational living. So there's a lot of stuff happening in the world to help us plan with all this bad news that I just finished talking about. So um, there is just what drives a lot of it is labor and insurance because we like to sue each other in America and we like to give higher wages to our citizens. And those things are driving up costs. And that's really what happens with most of the costs. So right now, hospitals, I'm going to go through these very quickly. Hospitals about $7,000 to $10,000 a day. And then if you go to rehab, it's about $1,500 a day per bed. And then if you go to skilled nursing, it's going to be about, it says here, $306 a day. This comes from Genworth. 11,000 per year with a shared room. This is skilled nursing facilities. We call them SNFs. A private room is being more expensive. So if you look at a private room in a skilled nursing facility, you're looking at $127,000 a year. And then if you, this is the cost of skilled nursing facilities, how it keeps going up. It's quite the challenge, as you can see. Um, uh, PACE is an interesting program, and I might skip over it a little bit. I want to come back to it because I think PACE is an answer that has great possibility. But then you have skilled home health care, which is skilled, and that usually is what you get after you go to the hospital. Um, and I've already mentioned that it used to be 30 days, now it's about 20 days, and now they're dropping the range of motion for PT and other things. So that's skilled care. And then hospice, we already mentioned, and most people don't choose hospice until about 2 weeks before they die, and hospice is awesome. And so the hospice will care for you and take care of your pain and other stuff. You can't keep getting restorative treatments, but hospice is a great option if you just want to say, I'm going to let nature take its course. Hospice covers a ton of stuff. And ironically, you can get discharged from hospice. We know several of our clients in home care that went into hospice and then they got better and they came out of hospice. And so it's great. Independent living is where you mostly are on this call. Huge range of options. And then CCRC is Life Plan Communities. That would be Goodwin House locally, or Erickson over at in Fairfax County, the Erickson Properties, Leisure World, Green Spring Village. These are places where you can do the whole continuum of care. You move in as an independent, and then you have assisted living, then you have nursing facilities, and then you have hospice, all built into one community. And then assisted living facilities getting more expensive. It's going to be about an annual, for one bedroom, about $100,000 a year. And then you have these assisted living costs. And then this is costs for assisted living in the United States. And then home care, which is where I live with ACC Family. It's going to be, the DC metro range is $26 to $40 per hour. And we can talk about home care if you're interested. It's the bottom of the circle, and it's the least expensive. And then here, home care costs, as you can see, keep going up. And then in DC, home care costs are about $34 an hour on average, is what the average person pays for home care in the DC area. Let me look at the chat. I see. Linda was saying there's no time limit by regulation for home health care, the skilled part of it, as long as the patient requires a nurse, physical therapy, etc. for homebound. And there's no lifetime limit. That's excellent, Linda. Thank you. I was not aware of those provisions, which is great. Then there's adult daycare, and it's average $75 a day. And then villages is where you guys live, and I love it. Started in Boston, and it's also goes by the moniker NORCS, a naturally occurring retirement community. And there are 30 villages in DC, more than any other city in the United States. DC has more villages than anywhere else, and great stuff that's happening here. So there's, I will mention this, intergenerational dwelling units, or ADUs. They're granny pods. You can get basically it's like a mini house that they either build or drop into your backyard, and you have retirement options that your grandparents or parents or you can live in the backyard of your children, and they hook it up to sewer and water, and it's a freestanding alternative dwelling unit, and you can live with your children without having them have to renovate their house. There's a lot of zoning issues now coming up with this, and the city of Alexandria is struggling with this, as you might imagine, but these are workable things. And then intergenerational living is where people are starting to have younger and older people all move in together, and that is intergenerational living is how we've survived for about the last 6,000 years of history, is that we all live with each other, and that does in fact become an option. Okay, I'm going to skip through a whole bunch of other things because I want to get to some of the solutions with the time that we have left. Um, the I'm looking at the chat for Linda. Um, the hospice physician must certify that in hospice, the person is terminally ill within 6 months or less. And that's exactly right. Thank you, Linda, for that data. Okay, so how are we going to pay for all this stuff? Overview is that the systems that we may be depending on are running out of money. And so here are 11 different ways that you can begin to layer ways for you to save money. Number one, insurance policies, if you can leverage them. If you have a life insurance policy, you can add a home care rider to it, and your life insurance can be drawn down before you die to pay for home care. Now, you have to ask around for that, but some folks have life care that pays upon death of the person, and you can set up those that you can draw down some of your life care benefits to pay for home care before you pass away. If you are a veteran, there's Veterans Administration has benefits if you qualify, and so you should use those if you've served the nation. Challenging, but if you have home care needs and you own your home, you can take out a loan against the equity on your home. There's three different ways or four to do that. You can take out a line of credit against your home to pay for home care. You can do a reverse mortgage. Some people love those, some people don't. A reverse mortgage basically says instead of you paying the bank for years and then you finally get your house, you own it, you reverse that and the bank pays you a monthly mortgage payment to stay in your own home, and then when you pass away, the bank owns the house, and whatever's left goes to your estate. So there's lots of good and bad, but most of the folks that are in Arlington Neighborhood Village may in fact own a home or in the home ownership side of the world, and you can leverage that to pay for care if you need to. There is assisted living flexibility if you want to come in for respite care and I'm not assisted living, I'm home care, but you can work with assisted living to be more affordable and help with care. You can look for open beds in those facilities and bid for lower prices, because assisted living, even though they want to charge a certain amount on paper, if you're willing to be in one of their bedrooms, they might be willing to work with you on a price that is affordable. So always you should check. Earlier chat addressed this. Are there non-profit or not-for-profit organizations that give their profits back to the community instead of to shareholders? And I have down here, discount the glitz. There's some facilities that are absolutely beautiful, but you're paying for all of that. So I always say, maybe there's less expensive, less glitzy options that do just as good to care for you. And then details, sometimes facilities won't let you bring your pet in, or they will cover only one meal a day and you have to pay for the other two. They won't dispense your medications, you have to pay for that yourself. There's all sorts of little ways that facilities might in fact need to nickel and dime you to death. So watch out for that. There might be gaps, and then look for gaps in the coverage that may exist. So here is a conclusion. The big deal is I am an advocate of going to a village, the village concept, and joining a village, because that is the best way for you to age in place, in my opinion. Most of the things that you need, like shoveling your walks so you don't fall down, or getting food in the house if you're snowed in, all of that, it's the same thing we've been doing in America and the globe for the last thousands of years, is that we need to care for each other. And so a village is the least expensive, best option for you to age in place. And our home care company will give a large hourly discount if you're in Arlington and will join the Arlington Village. Then you get a discount on home care for us, because we want to push people toward a village. And so most of the things, Gary's on the call, and we talked about this before we started, There are things that just drive you batty that a volunteer can help you with before you ever have to pay for a professional service. So join a village. It does take a community, and the more that you can tie into Arlington Neighborhood Village, the better, healthier everything will be for you. Uh, Join a community, join a village. If you are thinking about moving out, it's actually better to move closer to a city center. And that's because if your shopping is within walking distance, transportation is walking distance, all those the all those services are closer to it. The closer you are to a city center, the better you will be in terms of aging. And ironically, most of the labor that can come and help you are going to be based in the city as well. So closer to city centers, move in with family is an option. And that's how we've dealt with it for the last 6 or 7 thousand years of human history. And so there are different ways to navigate moving in with your family, but that is a great option. And make friends with your kids, because in the end, if everything falls apart, it's going to be your family that helps you. So I've got a little less than 10 minutes left just for Q&A. I dumped information on you guys. I'm sorry, but I want to get through it.
Jim, can you post a website for your company? We had a couple of questions about specifics of what do you provide and what does it cost and that kind of thing.
Yeah, I will put in the chat. See if it's typing right. Uh,
You had also posted your email address, but I think there was a typo in that, so you might want to
oh,
post
okay,
that
I'll take
again.
that. Um, and then I'll put my email again, typing carefully. Oh, yeah. Okay. So in the chat is our website and my email. And one of the things that we do is our core values are loving and serving. And so everything that we can give is free until the caregiver, in our world, the caregiver actually shows up to your front door. So you can feel free to utilize me for questions and for consultations, and I'll come meet with you in your home for free. And there's too much information for us to digest in one setting. And so if you want me to come over and talk through these things, it's my joy to do so.
So that ties into another question. Are there advocates or case managers or other people out there that can help us deal with all this? And how do we find them?
Great question. There are advocates, and this Virginia will provide an advocate to help you understand the system, but they're relatively underfunded or not funded at all, and so it's the word on the street is that you wait a long time for help. But I can find the website for advocates, and in the follow-up that we have, I will send it. I'll try to send it out. There are things called case managers who will be usually a nurse that will help you manage all of your case. They'll be at the hospital if you're sick, and they'll help you understand Medicare, Medicaid, etc. Um, you have to pay for those case managers, but those case managers are available for you, and they give you the full spread. So where home care, we care for stuff. We basically become a surrogate family member in your house to help you take care of all of that. A case manager will be sitting on top of it that says, I'm going to look, make sure your roof is done. If you need to have a roof leak or your pipes burst in the cold, I'll help you get a plumber. They manage your whole life. They help you do it. Uh, they can be expensive depending on who you choose, but that category exists. So Lighthouse is one of the case managers that we work with, and uh, another one is Elder Tree. both of those companies we work with, or Lionheart. There's another case manager that we work with. All of those are great folks that we work with. Yeah, Steve asked if we were part of the Atlantic Coast Conference. No, and in fact, a quick funny story are when we started, there was no licensure, there was no internet, and there were no cell phones. It sounds like I was with the dinosaurs. So we thought founded our company. We said, well, we care for adults, so adult, and we do companion type stuff. So we said adult, and we're companions, and we care for people. So adult companion care. And when they created the internet, believe it or not, we started getting these really weird messages, and the internet thought we were a prostitution service, adult companions. And we're like, oh my goodness, we are not that. And so we had to change our name, and ACC, Atlantic Coast Conference, couldn't use. So we had to stick the word family on the end of it so that people would get our emails and we wouldn't be considered something less than morally pure. So that was quite the experience. Other questions?
Quick question here. What's available for a short-term rehab situation after surgery?
So ideally, without knowledge of that, when you do surgery, you should be able to go to a rehab center, and that is a part of Medicare. They'll send you there to get your rehab finished up. If for some reason your surgery is not covered by Medicare or not covered by your health insurance, then I would be eager to talk with you, and I could show you the rehab centers that generally do better work on short-term stays. But for the most part, if you have a surgery and it's in a hospital, your insurance company and or Medicare will send you to a rehab as a part of your recovery process.
And isn't deciding where you're going to go generally part of the pre-surgical consultations?
Yes.
My sister-in-law is about to have a surgery, and she said she thought it would be one meeting with the surgeon and then let's schedule it. And it's a whole litany of things that they want to nail down,
Yeah.
and that's one of them.
Yeah. And there are lots of different facilities that will give a rehab bed. And so if you're in this sector and you have an assisted living facility and you have 100 beds, you might dedicate 20 of those beds to rehab. And then when you get out of surgery, you're actually going to an assisted living facility. And they're more than happy to have you stay eternally from if you want to pay for that. So those beds are allocated among different places. And sometimes you have a lot of choices, and it's really hard to figure out which one you want to go to.
Do you work with clients who have dementia or other psychiatric issues?
Yeah, we have a large portion of our clientele that are some version of dementia, and our caregivers are trained on dementia. And then we have continuing education units that they do that keeps their education topped off on the latest research for dementia. But yeah, there's a large portion of folks that have dementia or other disabilities, and we are working with a whole spectrum of those.
Okay, if we got any other questions?
In the home care, I will say one thing that's a strategy in the home care sector. Most people say, I'm going to get 24/7 care in home, or I'm going to go to a facility. And I often find myself saying, don't pay for somebody to watch you sleep. If you're sleeping, then don't pay for that. So most home care comes in 4-hour segments, and it's the least expensive option as long as you're not paying for 24/7 care. Most people don't need that until right at the end of their lives. So there are all sorts of layers that you can add in that make it less expensive and affordable for everybody.
I've got a question. What's the difference between home health agencies and handling home care workers by yourself?
Thank you. That's a great question. And I'm conscious of the time, so I don't want to abuse the time for you guys. But
They can't even tell anything, anywhere to go.
I'm sorry, I didn't check that.
What?
I'll, I'll answer that question, whoever was just mentioning that. You can hire home health aides, home care aides by yourself. and you're going to pay less. The challenges are that if you hire by yourself, it's just a risk tolerance. How much risk do you want to take? Because the risk is that if they have a childcare issue or they get stuck in the snow or whatever, then there's no backup, and home care agencies have backup. And then there are a lot of laws that are applying when you hire somebody privately, and you have to technically uh, abide by those laws. It sounds, of course, silly. You have to abide by those laws. Most people are going to be so small in their expenditures they won't count. But technically, if you hire somebody to be in your home, you are considered by the government as their employer. Therefore, you have to pay their taxes. You have to have a workers' comp policy for them, and you have to file their taxes on a quarterly basis. And most people don't want to mess with that much work. What often happens in home care that we find is someone has hired privately a person, and then that person claims to have a soft tissue injury. Oh, I hurt my back or I hurt my shoulder, and then they file a workers' comp claim against the person that hired them, and you didn't have a workers' comp policy, and it turns into a mess. And then Mrs. Jones, who's 84, suddenly is having to navigate with a lawyer to talk about workers' comp claim. And there are caregivers that are being coached on how to do things like that in order to get money. It's immoral, but it happens. And so if you have an agency, then we're dealing with all that. You don't have to worry about it. But agencies are more expensive because we have to pay all those fees plus the insurance. So it's kind of 6 to 1, half dozen the other. What do you want to do, and how much can you afford?
You mentioned earlier about drawing down your life insurance to pay for care. How does somebody go about doing that? Should they just call their insurance agent or?
Yeah, that's a great question, Gary. Yes, call your insurance agent and say, can I add a home care rider to my insurance policy? And every policy is different, but you can, depending on how flexible the insurance company is, they will give you an amendment that allows you to pay for home care. And if they will do that, it's a great option, because that way you're using that whole life insurance policy that's sitting out there for your use as you age. But it's individually, the individual insurance companies will be the ones to talk to. The
So it
other
sounds
question,
like home care rider is the phrase we need to keep in mind.
yep, yep, home care rider. And then one of the things that we offer for free is if you have a home care rider or you have a long-term care insurance policy, um, those insurance companies, as you know, they love to take your money, but they're not too happy about giving it back. And so they will want to um, have a piece of paper that justifies what happened in the home for every shift. And that can be overwhelming. It's really, and they won't pay until they have that. It's called a daily progress note or a daily visit sheet. And so one of the things that we offer as an agency is that we take care of all that for you for no cost, because that can drive you bananas trying to get every I dotted and T crossed. But if you use a policy like that, they're going to want a piece of paper, digital or physical, for every shift in order to justify paying you back for the use of your policy. So look at whoever you care, however you're going to use that policy. Make sure that there's some help there for the paperwork. Pardon me. Um, the question from Pat is long-term care policies are not the same as life insurance. That's true. They're different policies. Um, the long-term care industry did its actuarials incorrectly, and so they offered them early on for everybody, and they did their numbers wrong, and now they're too expensive they're dragging down insurance companies. And so the long-term care industry, for instance, out of the 10 top players that offered long-term care policies in the past, 9 of them have stopped selling them altogether. You can't even buy them anymore. John Hancock was a company that sold to the federal government for years, and a lot of people that we work with have a John Hancock policy, but they won't sell you any policy anymore because we're living longer and they can't keep the policy going. So a lot of the long-term care policies, either you can't get them, or if you have one, the annual premium goes up by 40 to 50% every year because they're needing to bring in money in order to pay for the beneficiaries. So long-term care policies, if you have one, don't stop paying that premium. Oh my gosh. And if you don't have one, they're so expensive now, they're almost not worth it. But that's an individual choice.
The question here about language difficulties between home care workers and clients. And I wanted to add to that a question to you. Are people finding it harder and harder to recruit home care workers? Most of the ones I've dealt with have been from African or Caribbean countries. And given all the immigration chaos in the country right now, is that becoming harder and harder to do?
Yeah, the quick answer is yes on all those questions. Is it there was a caregiver shortage before, and now that there are people that are being pursued by ICE to be removed from the country, uh, it is causing jitters in that sector of the market, and more people are less inclined to do it. We only hire people that are completely legal, so we don't have any problems with ICE. But that community is much more skittish now with the ICE enforcement. And there was a shortage before, and now it's getting harder to find good caregivers. The the caregiver base demographically on the eastern seaboard is predominantly African or Caribbean, and this you're going to get the same aid whether you're in a facility, in the hospital, in home care, in skilled care, or adult daycare. The same people are going to be working in all of those places. So when you're looking at an aide in the hospital or assisted or rehab facility, those are the same people that are going to be in home care. And so language is a challenge, and we test for language, and you can't serve with us if you don't speak English clearly. But some folks speak it more clear than others. And so we find ourselves saying, what is your heart? This is toward a caregiver. What's your heart? Are you willing to serve? And then we want to make sure you can speak English, because if you can't communicate, you can't serve. And then we try to match people at best we can. And we've got some folks that speak beautiful King's English and are as cold as an ice cube. And then others that you can hear them kind of, but they're superb caregivers. And so we just go, okay, what we want to link you guys up, and then you have to be able to communicate. But it is a challenge.
What kind of vetting do you do on the care workers that you hire?
Yeah, so we have an exhaustive vetting process that includes background checks, about 7 to 10 background checks, and then licensure checks, legal checks, citizenship tests. Then we do an interview with our director of human resources. Then we do an interview with the city director, and then we have people that are interacting, schedulers or care team leaders that are interacting. So by the time a caregiver comes into our agency, we have checked them some 25 or 30 different data points, and uh, and we have great folks working with us. But we've had people that get through the net and turn out to be knuckleheads. So we do our best to vet everybody with multiple interviews, reference checks, police checks, but uh, but then we interact with them and make sure that they're good people. We have a somebody that decides to do something silly like take jewelry or whatever about once a decade. So we've had 3 issues where caregivers stole something. We're insured for that, but when somebody steals grandma's diamond ring, it doesn't have as much physical value as it has emotional value. So we say, put all that stuff away and keep it from out of sight just for general security. But some people do things that are wrong, and we've had to send 3 of our caregivers to jail because of it, and we did that. So So nobody's perfect, but we're trying to keep everybody that's bad out of our database.
Okay. Got a couple of comment and a question. One was Goodwin House has mentioned that they had to let several of their care workers go because they had working visas, but they got pulled, so they couldn't work for them anymore.
Yeah, and we're going to only hire for us. We're only going to hire people that have gone through the process and they have citizenship. We don't mess around with the visas or sponsoring caregivers, but that's a challenge. Staffing across the board is a challenge.
Are home care workers required to provide their own transportation?
Yes, we have some caregivers that don't have cars, and so they get there however they can. But if you're a caregiver that is a driver, then your job is to get to the site, and you can. Some agencies apparently charge commuting fees for caregivers. You have to pay to have them to get to the house, and I'm like, that doesn't make any sense to me. So for us, the caregiver only starts the clock ticking when they come in the front door and say, I'm here to help. And we've given them what they need to do. So they have to do their own transportation to and from. And in the case of a snowstorm, we actually have caregivers that we pre-positioned in homes so that before the snow started falling, if somebody needed care, we put a caregiver in their home the night before so that when the snow hit, there was care that was already in place. And we have all sorts of ways to help people get the care they need.
All right. Well, it's 12 minutes after 11. I think we've hit all the questions, so maybe we should wrap this up and let you get back to your job.
Well, it is a joy to be with you guys. And I was at the Thanksgiving dinner and I was at the Christmas dinner, and we are loving doing life with Arlington Neighborhood Village. So,
All right.
I will, if we want to stay on for a second, I will take the presentation and put it into the chat.
Okay.
If I can get my mouse.
Yeah, and if you could also just email it to either Liz or me, and that way we can forward it to the office and they can have it up for anybody that comes in after the fact.
Okay, I'll do that for certain. Yeah, it's the chat's not letting me do it for now for whatever reason. So I'll email it to you guys and then you can have all this information to digest.
Okay. All right. Well, that was a lot of information. So,
Thank you for your patience for going all the way through all of that stuff. And I am at your disposal if you have any other questions. Would love to talk with you guys.
all right. Well, with that, I think I'm going to go ahead and close us out.
Have a great day, stay safe, and apparently we're having more snow on Sunday. So